So, immune deficiency infectious disease is what's new. I'm not quite sure I did exactly what Lenny was thinking I would do, because in past years I've done this immune deficiency, genetic immune deficiencies, and how they have been abnormal. But I thought what he wanted was an update on what's new in terms of immune deficiencies in our diseases. And so, Lenny, if I've missed the nail on this one, sorry about that.
It's all good.
With our diseases, there's sort of two groups of patients. We've got the low-risk patients and the high-risk patients. And the low-risk patients are the vast majority: rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. And the high-risk ones are lupus, myositis, and vasculitis. And this is in terms of risk of infection. What I'm going to do first is give some background, because I think that some of the things have not changed that much, or some of the principles haven't changed that much. One is that if you go back to the population-based studies that were done at the Mayo, patients with even mild diseases like rheumatoid arthritis are relatively mild in terms of infections, even before we had biologic agents, had markedly increased rates of infections. And this is the relative risk for the population of Olmsted County with and without rheumatoid arthritis that are all matched. You can see that, interestingly, septic arthritis and osteomyelitis were dramatically increased in people with rheumatoid arthritis, and this is even apart from joint replacements. Pneumonia was also significantly increased. Virtually all of these infections were increased. This is just on the drugs that we had back in the 1990s before biologics. When biologics got introduced, there's a lot of interest in the increased risk of infections with these biologics, and it's really becomes very complicated. And this diagram, this one figure, sort of summarizes a lot of the risk, and so I like it a lot. It's from 2011. It was a registry where they followed people very carefully who were put on TNFs versus people who remained on DMARDs. But what you can see here is the effect of some of the different parameters on the infection rate. And you can go down here from basically about 1% back up to here, where you're almost getting 50% serious infections. These are infections that you need IV antibiotics or you need to be hospitalized to treat. And the other thing is that the difference between DMARDs and anti-TNFs was definitely significant, but it wasn't as significant as what happens when you have other factors added in. So going across here on this axis, you're going from low-dose steroids to high-dose steroids, or at least actually almost no steroids to moderate-dose steroids. And you have a very dramatic effect on the infection rate. And then going front to back, you're going from no additional risk factors to up to 3 additional risk factors. So the risk factors in the first 2 steps are things like age, and they're calling old over 60, which I don't like, but 2, whether you have heart disease, whether you have kidney disease or lung disease, and 3, did you fail multiple DMARDs before? And the last step is whether you've had serious infections before. So you can see that you can look at a patient and you can stratify them fairly accurately in terms of what their risk of getting into problems with infections, just on the basis of clinical data. What's really interesting is they had this peculiar observation in a lot of these registries that people when they were first put on anti-TNFs, they would have a high rate of infections, and then it would go down as they followed people in these registries over time. So it looked like, looked like you got a pretty good result overall. You went back to the sort of the rate that you had with DMARDs. And this is shown over here. If you look at the incidence ratio between being on a DMARD to an anti-TNF, in the first year it's over 2. Second year, it's getting close to 1. Third year, it's less than 1. So what was interesting is they sort of went back and analyzed what were the different factors that changed and why was this infection rate going down. Because I think we all realize when we put people on anti-TNFs, we start getting rid of the glucocorticoids, which is we showed in the previous slide is a big effect. But only, sort of the improvement due to the decreased risk because of glucocorticoid reduction or because people were actually functioning better, and that was one of the risk factors they found as well. That only explained about a third of it. 2/3 of the decreased risk was actually on the basis of everybody in this room who sort of looked at these patients and said, boy, they're high risk. Let's not put them on these drugs, drop them out of the study, put them on DMARDs or switch their drugs around so that they weren't on anti-TNFs anymore. So the lesson here is you have to really worry about some of these long-term registries and what they're really telling you. It may be telling you that the doctors recognize the risk and they're dropping patients out of those registries on high-risk drugs. So this is a typical sort of pattern of infections in anti-TNFs. The serious infection rate is about 4.7. That's about twice the rate of a DMARD. They do have some tuberculosis. They have some serious zoster, but it's less than 1 in 1,000. Opportunistic infections also less than 1 in 1,000. So this is pretty consistent across most anti-TNFs and most biologics in general. I mean, the exception is that, with the anti-TNFs, the risk of tuberculosis and other facultative intercellular organisms goes markedly up. The reason I like this study is because they looked at what influenza vaccination did in these people, which is unusual in most of these studies. They looked at all the people that they were following long term on adalimumab and found if you didn't get immunized with influenza for that season, you had about a 14% chance of getting influenza. If you were immunized with influenza, you had about a 4% chance. So that's a relative risk of over 3. That's pretty good, and I'm sure we won't hit that this year, but that shows that there are interventions which are very important. Some of the newer agents, this would be sort of what's new, is the long-term safety of something like tofacitinib in rheumatoid arthritis, looking at serious infections, and just looking at what are the risk factors for this drug as well. And they're pretty much all of the same risk factors that we showed back with the anti-TNFs. So age is a risk factor, and this goes up 1.4 for every additional decade, so it's really a major factor. COPD, how much glucocorticoids you're on has an effect. Whether you have diabetes and what the dose of tofacitinib is. So the higher the dose of tofacitinib, the greater the infection risk. So that was sort of some of the news from long-term follow-ups of biologic agents or new agents, new DMARDs. The other news, I think, in terms of infections is the recommendations that have come out for what you should do when you have people undergoing orthopedic surgery, which comes up repeatedly. And so this is not truly evidence-based, but it is guidelines that are based on expert opinion. There's very little weak data that supports this, but basically, if people are on the conventional DMARDs for inflammatory arthritis, don't change them. Just continue those. You don't have to stop any of those. If they're on a biologic, then you want to stop that biologic sort of for 1 round plus a week is what they did. So if you're on a drug that you give every week, you stop it for 2 weeks. If it's every month, you stop it for 5 weeks, etc. And you keep them off of it until basically until the wound is healed, and they're doing well. The other thing that they recommended, and this is something that I always wondered about, and of course this is opinion and not really data, is that you shouldn't be giving stress dose steroids to all your people that are on steroids chronically and undergo these orthopedic surgeries. You should just maintain their daily dose, which is, I hadn't seen that as a recommendation before. I think that that's new and interesting. For severe rheumatoid arthritis who get these procedures, they do recommend that you continue all of their medications, basically. But if they're doing well, then you stop them for a brief period of time. Okay? So the next thing of interest, I think, is something that probably you all know about, but we're going to check. It's not that the Mycobacteria are more common in patients on anti-TNFs. This just shows that. This is the RA population not on anti-TNFs, and this is the RA patient on TNFs. Very dramatic increase in the risk. I would point out, however, that you can get the same kind of increased risk with steroids. So that if you're looking at the risk of tuberculosis in people who are on glucocorticoids, not on glucocorticoids is 1, and if you're on less than 7.5, your risk goes up to 2.7, and if you're on greater than 7.5, your risk goes up to 7.0. So the risk of glucocorticoids is every much as great as the risk of anti-TNFs for mycobacterial and some of these other infections. And what has come out, is that you should really be screening. This has been done so well in most of the studies that we can no longer, with the new agents, know whether there's an increased risk of TB or not for most of them. Because, if you do screen aggressively for anti-TNFs, you really reduce the risk of developing tuberculosis pretty dramatically. And so for all of the new biologics where the FDA has just said there's a warning, screen, we don't know what the risk is. So I don't know whether tofacitinib, for example, has an increased risk of tuberculosis or not. And what's interesting to us is, in Rochester, we're a low-risk area, and obviously our patients going on most of these anti-TNFs are not very immunosuppressed. So we've been screening usually with just a single test. But there's very good data now that the tests completely disagree. 80% of the time when you do more than one test for tuberculosis, they disagree. So they are recommending that if you have any risk, any increased risk for tuberculosis, if you live in a country where there's increased risk, maybe if you live in New York City, I'm not sure how much the risk is up there, but you should be doing at least 2 tests, and if they've had a history of BCG, those should be 2 interferon-based tests. So Pneumocystis Carini, I think there's some news in that people should know about. This is a short sort of retrospective study from Hopkins, which is of importance. These are 21 cases of pneumocystis over the past 20 years. They were primarily, there was about 1 a year, basically, in Hopkins. None were on PCP prophylaxis or PJP prophylaxis. Most were on prednisone, and if they weren't on prednisone over 20, they were on some immunosuppressive drug. Almost half the people died. Now, the reason that I'm interested in this is because of Hopkins and Lupus and Bactrim. There were reports of patients with lupus being treated with sulfa drugs and developing severe flares of lupus. I think this was Mary Betty Stevens reported this many, many years ago. And so they have been very reluctant in Hopkins to use, at least some of the investigators have been very reluctant to use Bactrim for PCP prophylaxis because of the risk of lupus flares. And I've had sort of a running discussion about this with the folks there, because lupus is like AIDS. You get activation of the immune system. You're more likely to get drug reactions if you have lupus. And if you're a lupus patient and you get a drug reaction, you're going to have a flare because, if you release all of those intracellular antigens, you've got the immune complexes, you're going to have a big inflammatory response. But I always thought that, if you're immunosuppressed enough to be prophylaxed for PJP, then you're probably not going to have one of these reactions. And so I think it's easier to use and you get better compliance. So that's what we've been doing. But I didn't really have any real data to support that, but now I do. So this is a study from Korea where they were using Bactrim prophylaxis for PJP. They treated 1,500 episodes where they identified 1,500 episodes where they had prolonged high-dose steroids over a 12-year period. Only in about 262 of these, which is the minority, were these people prophylaxed. What you can see in this graph here is the dose of steroids and whether or not they got PJP pneumonia. And you can see that there is a dose-dependent increase in the rates of PCP, but it's still, it's still only a very small number of people that get it. And the people that were being treated for this, it was interesting. Most of them were lupus. At least that was the high percentage of people had lupus. But there was the other people that you would be very immunosuppressed as well, the myositis patients, the inflammatory myopathy, and the vasculitis. So those people in the high-risk group that we talked about at the beginning. And they showed that if you were treated with Bactrim, not only did you not have a dramatically decreased risk of PJP, it's 0.06% risk, but you also were much less likely to die. So this is what I was mostly interested in. This is their incidence of adverse drug reactions with Bactrim. And they go through, there were a number of reactions, as you can see, anemia, leukopenia, thrombocytopenia. Those are all sort of non-immunologically mediated, but they did have skin rashes, and they did have some serious drug reactions like Stevens-Johnson's in one person. But what I was interested in is they treated a lot of people with lupus with this, and they had no flares of lupus. Okay, so at least there's some data out there to justify, using Bactrim prophylaxis in patients who have lupus and are immunosuppressed enough to need prophylaxis. In terms of another important disease for patients with rheumatic diseases, I think Lenny has probably done more than anybody else on this particular disease. This is PML, and this is all the different ways you can look at PML on an MRI with different sequences. For the people with MS, they have a very, who might be treated with natalizumab, they have a stratification protocol for handling those patients where they check serology, and then they decide on the basis of that, whether they're going to treat them and for how long they're going to treat them and how often they're going to get MRIs. We don't have that, but we have this stratification that Lenny came up with for risk of PJ, of multifocal leukoencephalopathy, based on what kind of baseline risk people have. So, if you're treating people with these drugs that affect trafficking of T cells into the central nervous system, like natalizumab or afilizumab, which is no longer available, your risk is very high, like 1 in 100, if you're on these drugs for a prolonged period of time. The other set of drugs where there's some increased risk are things like rituximab, belimumab, and the risk there is primarily possibly in the population of lupus patients, and as well as the common, immunosuppressive drugs that we've used for a long time, like Cytoxan. Very low risk are all of the drugs that we're using for the inflammatory arthritis. In fact, there's many of them where they have no confirmed cases. And so this is very helpful. I guess we have gone to checking patients' serological status for JC virus when we're talking to them about using rituximab, especially in the lupus patients. It's not as big a problem in the RA patients, but we discussed whether we should check it and whether they would want to take the drug if they were positive or not. Hepatitis B reactivation, I think that this is something that is, we all check, for hepatitis B and C before we put people on any of our drugs. And, the thing that is, I think, new now is that we used to use a different antiviral, but now we're using some of the newer antivirals for patients with hepatitis B. And the other thing that I think is important to realize is rituximab seems to be, of the drugs that we use, rituximab is the bad actor and the one that you have to be most careful with in terms of hepatitis B risk. Denosumab, Prolia, has been a great drug for osteoporosis. There's some data from Japan where it's also a pretty good drug for erosions. And so, you've got to think about whether or not we should be using denosumab in some of our patients with inflammatory arthritis. You can get sort of a 2-for-1, potentially. This is showing, for different doses of denosumab, how much of a decrease in your erosions you get. So now the problem is it's a biologic, and there's been a lot of concern about whether or not using it with other biologics is allowable because it might have an increased risk of infections. There's now been a study from Japan where they've looked at denosumab versus zoledronic acid in people who were treated with biologics, and what they found is that there is no increased risk of using denosumab with biologics. So some of those people that are on anti-TNFs and you're thinking about using, or other DMARDs, and you're thinking about using denosumab, that's now something that would be very reasonable. There's going to be another talk later on about vaccines and how you use those in some of these patients. I think in terms of news, the vaccines are probably the biggest news, and so I'm not going to really touch on that. And I'd be surprised if this is mentioned, but we all give a lot of influenza immunization in our offices. Until this year, we were all asking about egg allergy. You should all stop asking about egg allergy, no longer ask about egg allergy. Even if they have anaphylaxis to egg, they can get the flu vaccine. It's not a problem anymore. But of course, if they've had anaphylaxis to the influenza vaccine, that's still a problem. So that's not the same thing. So, okay. So I'm going to stop there.